So imagine you've got a 50-year-old patient crashing right in front of you. I mean, they are cold, they're clammy, and their blood pressure is, well, it's completely unrecordable.
Oh, that's just a nightmare scenario on the wards.
Right, and the monitor is just flashing this insane heart rate of like 300 beats per minute. You've got this little strip of paper with chaotic squiggles in your hand, and you have, what, maybe 10 seconds to decide?
10 seconds on a good day.
Exactly. You have to choose whether to push a drug or just immediately reach for the defibrillator paddles. And if you make the wrong choice, I mean, it is fatal.
It really is. And that right there, that's the absolute reality of clinical medicine. It's not the neat, linear, chapter-by-chapter progression you get when you're sitting in a library reading a textbook.
No, definitely not.
It's just this landscape of total diagnostic unpredictability.
Yeah.
I mean, you don't get to choose the pathology that walks through the clinic door next.
Yeah, they don't wear a sign saying what chapter they belong to.
Exactly. And that's why relying solely on like pattern recognition from some pristine reference manual, it just falls apart so quickly in the emergency department.
Which is actually the exact premise of our deep dive today. We are taking a really comprehensive look at the book 150 ECG Problems by Emeritus Professor of Cardiology John R. Hampton.
It's such a brilliant resource.
It really is. And our mission today is to help you bridge that gap between basic theory and that super muddy, high-stakes clinical application. So just as a heads up, we aren't reviewing how to attach leads or, basic intervals today.
Right. We're assuming you know the basics.
Yeah. We are pulling the core clinical pearls directly from Hampton's work, and we're focusing intensely on the pathophysiology and the management.
And honestly, the methodology of this text is what makes it so incredibly useful for your actual clinical practice. The scenarios are presented completely at random.
Which feels super chaotic at first.
It does. But it perfectly mirrors a real-world shift. Like, you might face a totally benign physiological variant 1 minute, and then boom, a cardiogenic shock the next. You don't know the difficulty rating of the case until you flip to the answer.
But okay, let's unpack that for a second. Isn't it, I don't know, a bit overwhelming to get hit with random, ungraded cases? It feels almost like getting a pop quiz every single time you open a clinic door.
Well, yeah, but that is the reality of medicine, right? You are forced to interpret that electrical tracing strictly in the light of the patient's clinical presentation before you ever know the underlying diagnosis.
Because an ECG in isolation is just a piece of paper.
Exactly. It's totally meaningless without context. It requires synthesis. So let's actually look at how that synthesis works with some of the deceptively benign presentations you'll encounter.
Okay, let's do it. Consider this. You've got a 25-year-old pregnant woman presenting to your clinic, and she's complaining of palpitations, just this sort of irregular heartbeat.
Pretty common presentation.
Very. And on auscultation, you note a soft systolic murmur, but the rest of her cardiovascular exam is, otherwise totally unremarkable.
Okay.
Because you pull an ECG, it shows sinus rhythm, a normal axis, normal intervals, but she has these frequent ventricular extrasystoles. Now, I feel like your immediate instinct when you see those early, wide complexes popping up might be to intervene.
Right, because you see an arrhythmia and you want to fix it.
Mm.
But if you synthesize that tracing with the actual physiological state of the patient sitting in front of you, the management pathway changes entirely.
Because she's pregnant.
Precisely. Pregnancy induces this massive hyperdynamic state. I mean, maternal plasma volume increases by up to 50%.
Wow, 50% is huge.
It is. And that massively drives up cardiac output. In that specific physiological environment, ventricular extrasystoles are incredibly common. And more importantly, they're usually entirely benign.
And I guess that murmur plays right into that hyperdynamic state as well, right?
Absolutely.
Because with that significantly increased stroke volume just pushing through the same valve orifices, you're going to get turbulent flow. It's just a classic physiological flow murmur.
Yeah, and you have to add in the dilutional anemia that's, well, it's almost universal in the second and third trimesters.
Right, because the plasma volume outpaces the red blood cell production.
Exactly, which decreases blood viscosity, and that just amplifies that turbulence even more.
So your management here is basically just conservative reassurance.
Yep. You do not treat the extrasystoles. In fact, the text explicitly warns against reflexively ordering an echocardiogram for every pregnant patient with a systolic murmur.
Because it's just a poor use of resources.
Yeah, it's a terrible use of resources.
Yeah.
Best practice dictates reserving the echo for murmurs that persist well into the postpartum period, once that plasma volume has actually had time to normalize.
Right. It's a perfect example of a normal abnormality. The tracing is technically abnormal, but physiologically, it's totally expected. But what happens when we move away from those normal variants and look at an electrical system that is actively being poisoned from the outside? Because external pharmacological agents leave these highly specific fingerprints on an ECG, don't they?
Oh, they definitely do. And digoxin toxicity is a prime example of this.
Oh, yeah.
When a patient is on a therapeutic dose of digoxin, you'll frequently see this characteristic downward-sloping ST segment depression.
It looks almost like a sagging scoop, right? Or like a reverse tick mark.
The reverse tick mark, exactly. But here's the thing. Spotting the drug effect is one thing. The critical clinical pearl here is spotting the catalyst that's pushing that therapeutic dose over the edge into toxicity.
Right. So say you're looking at that same tracing, but you also happen to notice prominent U waves, particularly in the precordial leads like V2.
Well, those U waves are the absolute hallmark of a hypokalemia, low potassium. And this is where the underlying mechanism completely dictates your management.
How so?
So digoxin works by binding to and inhibiting the sodium-potassium ETPase pump in the myocardial cell membrane. But the kicker is, it binds to the exact same extracellular site that potassium does.
Oh, I see. So they are directly competing for real estate on that exact same pump.
Precisely. So if your patient is hypokalemic, say, maybe they are on a loop diuretic like furosemide that's just washing potassium out of their system, there's less potassium around to compete for those binding sites.
Which means more digoxin binds to the pump.
Exactly. It heavily potentiates the drug's effect. So what was a perfectly safe therapeutic dose yesterday becomes highly toxic today simply because their potassium dropped.
That's fascinating. So the practical clinical application for you listening to this is all in the history taking. You see the sagging ST segments, you spot the U waves. You need to immediately ask the patient about their appetite.
Yes. The text specifically notes that the very earliest symptom of digoxin toxicity is anorexia, just a total loss of appetite, followed pretty closely by nausea and vomiting.
You obviously verify that with serum digoxin and potassium levels, but the ECG basically just handed you the entire physiological narrative.
It really did. Now, let's contrast that external pharmacological poisoning with an internal, just catastrophic failure of the electrical wiring itself.
Okay.
Consider a patient who presents after a sudden, completely unprovoked syncopal episode, and they sustain a fall. You run the ECG, and you see complete atrioventricular dissociation.
So complete heart block.
Yeah. The P waves are firing at a normal intrinsic rate, let's say 70 beats per minute. But the QRS complexes are completely divorced from them. They're firing at this slow, wide 45 beats per minute.
Right. So the electrical signal from the SA node is basically hitting a brick wall at the AV node.
Total roadblock.
And the ventricles realize they're getting no signal at all, so they trigger their own intrinsic escape rhythm just to keep the patient from dying.
Exactly.
And the reason those QRS complexes are wide is because that escape pacemaker is located really low down in the ventricular myocardium, right? Below the his Purkinje system.
You nailed it. The depolarization wave has to spread slowly, literally muscle cell to muscle cell, rather than shooting down those fast electrical highways.
And that slow ventricular rate just drastically drops the cardiac output, which leads to cerebral hypoperfusion and the syncope.
Right, a classic Stokes-Adams attack. And regardless of whether the patient remembers feeling dizzy before they fell, the management here is immediate.
They need pacing.
This patient requires a permanent pacemaker, full stop. If there are any surgical delays, a temporary transvenous pacing wire has to be floated immediately. You physically have to bridge that broken electrical connection.
Wow. Okay, so we've looked at what happens when the electrical wiring fails. Let's shift gears for a minute and look at what happens when the electrical system is perfectly intact, but it is forced to drive a structurally deformed pump.
Oh, this is where it gets really interesting mechanically.
Yeah, like how does massive mechanical strain alter an electrical tracing? Let's picture a 40-year-old woman referred to your clinic with progressive, severe dyspnea. Her ECG shows peaked P waves in lead 2, marked right axis deviation, and dominant tall R waves in lead V1, along with deep S waves in lead V6.
And you'd probably see P wave inversions across the right-sided and inferior leads, too.
Yep. So what's happening there?
You really have to visualize the vector physics here. In a normal, healthy heart, the left ventricle is massively thicker than the right. So the dominant electrical vector pulls leftward and posteriorly.
Right, away from lead V1, since V1 sits right over the right ventricle.
Exactly. And that away vector produces the normal deep negative S wave you expect to see in V1. But in this patient, V1 shows a dominant positive R wave. The whole electrical vector has completely flipped. The electricity is literally surging toward the right.
It's almost as if the right ventricle is, I don't know, a bodybuilder who has been forced to push against a jammed door for years.
That's a really good way to picture it.
The muscle mass of the right ventricular free wall has hypertrophied to such an extreme degree that it now electrically outweighs the left ventricle. So those electrical signals are literally traveling through a massive, heavy wall of muscle.
And in this case, that jammed door you mentioned, that is severe pulmonary vascular resistance. The text identifies these specific ECG findings as severe right ventricular hypertrophy, or RVH.
And clinically, the signs would align perfectly.
Oh, absolutely. When you lay hands on this patient, the physical exam will directly correlate with that tracing. You will feel a left parasternal heave because that massively hypertrophied right ventricle is literally lifting your hand off the chest wall with every single systole.
And you're going to hear a super loud pulmonary second sound, the P2, as that high-pressure pulmonary system forcefully slams the valve shut.
Yep. And don't forget the jugular venous pressure. If you look at her neck, you'll see that characteristic flicking a wave.
Because the right atrium is vigorously contracting against a really stiff, non-compliant right ventricle, right? It just sends a shock wave back up the jugular vein.
Exactly. The clinical imperative for you here is uncovering the etiology of this massive right-sided strain. In a middle-aged female presenting with this degree of pulmonary hypertension, you're primarily differentiating between recurrent microscopic pulmonary emboli that have been showering the lungs over time, or primary pulmonary hypertension.
Where the pulmonary arterioles themselves undergo pathological remodeling.
Right, so she needs a VQ scan or a CT pulmonary angiogram immediately.
Yeah.
And the management will undoubtedly involve long-term anticoagulation, but honestly, the mechanical consequences are just severe.
Yeah, the specific scenario detailed by Professor Hampton actually ultimately required a heart-lung transplant.
It's devastating. The mechanical destruction was absolute, but the very first clue to all of it was entirely electrical.
That's incredible. Okay, moving from chronic mechanical strain, we need to transition to acute, immediate life threats. Let's talk about the tachycardia emergencies.
Oh, the adrenaline pumpers.
Exactly. Let's return to the scenario we opened the episode with. When a patient's heart rate suddenly jumps to 250 or 300 beats per minute, you must differentiate the rhythm instantly. Let's compare two patients in profound cardiogenic shock. They are both cold, clammy, and hypertensive.
Okay, lay it on me.
Patient A is a 50-year-old man with a narrow complex tachycardia at a blistering 300 beats per minute. There are no discernible P waves, just a continuous oscillation with some secondary ST depression in the lateral leads.
Got it.
Patient B is a man with a known history of an anterior myocardial infarction. He is presenting with a broad complex tachycardia at 250 beats per minute, and the QRS duration is a massive 200 milliseconds with this ugly, just bizarre morphology.
Okay, let's unpack patient A first. A narrow complex at exactly 300 beats per minute. That is the absolute hallmark of atrial flutter with one-to-one conduction.
Because the flutter circuit in the right atrium circle is at exactly 300 beats per minute.
Precisely. Now, usually the AD node acts like a physiological gatekeeper. It blocks out every second or third impulse so the ventricles don't race too fast. But in one-to-one conduction, that gate is just wide open. Every single flutter wave triggers a ventricular depolarization.
It's kind of like thinking of the AV node like a bouncer at a crowded nightclub.
Oh, I like that.
Yeah. Normally he's stopping the line, right? Letting people in slowly, one by one. But in one-to-one flutter, the bouncer just falls asleep, the doors fly open, and everyone rushes the floor all at once. It's a stampede.
A total stampede. And the reason this patient is in shock is pure hemodynamics. At 300 beats per minute, diastolic filling time essentially drops to 0.
Wow, so they're just pumping empty air?
Basically, yeah. The ventricles are vigorously squeezing, but there's literally no time for them to fill with blood between beats. Squeezing on empty means cardiac output plummets and the patient collapses.
Right. Now what about patient B?
So, patient B. The broad QRS complex tells us the depolarization is not utilizing the his Purkinje system at all. It's originating from within the ventricular muscle itself and spreading slowly, cell by cell.
So this is ventricular tachycardia.
It is, and the absolute most critical clinical pearl here from the text is a fundamental rule of emergency medicine. In the context of ischemic heart disease or a previous myocardial infarction, a broad complex tachycardia must always be treated as ventricular tachycardia.
No exceptions.
Unless you have a prior tracing proving they had a pre-existing bundle branch block, no exceptions. you assume VT.
Because that post-MI scar tissue forms the perfect re-entry circuit for VT. It's the ultimate do-not-miss diagnosis.
Exactly. But the fascinating convergence here is that despite these being two completely distinct arrhythmias originating from totally different chambers, your acute management for both of these hypotensive crashing patients is identical.
Because they're hemodynamically unstable.
Right. There is zero time for pharmacological trials. I mean, antiarrhythmics take time to circulate and work, and these patients have no effective circulation.
So you shock them.
Immediate, definitive treatment for both is synchronized DC cardioversion. You must electrically depolarize the entire myocardium simultaneously to reset the pacemakers.
Okay, let's contrast that chaotic emergency with a hemodynamically stable presentation. Say you have a patient presenting with palpitations. Heart rate is a 180. The QRS is narrow, and P waves are either buried or retrograde. But they are sitting up, chatting with you, and their blood pressure is a solid 120/80.
Okay, so this is likely an AV nodal reentry tachycardia, or AVNRT. And because they are stable, you have the luxury of an escalating management ladder.
You don't have to jump straight to the paddles.
Exactly. You start non-invasively with vagal maneuvers like the Valsalva maneuver or carotid sinus massage.
And those techniques increase parasympathetic tone via the vagus nerve, right?
Yep. They release acetylcholine at the AV node to prolong the refractory period, which hopefully breaks that reentry circuit.
But if the vagal maneuvers fail, then you move to your pharmacological options, right? Starting with intravenous adenosine.
Adenosine is such a fascinating drug.
It really is. You give it as this rapid, large-bore IV bolus. It binds to the A1 purinergic receptors on the AV node, which causes potassium channels to open.
And then potassium just rushes out of the cell.
Exactly. Deeply hyperpolarizing the AV node and inducing a transient total AV block for about, 5 to 10 seconds?
Yeah, about that. And the patient will likely experience a profound sense of impending doom and severe flushing during those few seconds before the half-life clears.
It's terrifying for them.
It is. But the text includes a supravital contraindication you have to check for first. Adenosine can activate purinergic receptors in the bronchial smooth muscle.
Oh, triggering severe bronchospasm.
Right. It is strictly contraindicated in asthmatics. If they have asthma, you pivot entirely and use intravenous verapamil, which is a calcium channel blocker, just to slow that AV node down.
And you only move to DC cardioversion for a stable patient if literally every pharmacological option on that ladder completely fails.
Exactly.
All right, let's shift our focus for our final analysis to the most common presentation you will face in the ER, chest pain. We really need to distinguish actual ischemia from a pathology that mimics it almost perfectly.
This is such a critical distinction. Let's start with a really challenging ischemic presentation. Say a patient arrives with crushing chest pain and an ECG showing acute anterior ST elevation. However, they report the pain started over 18 hours ago.
Okay, so conventionally, strict textbook protocols might suggest they are well outside the window for thrombolytic therapy because you'd assume the myocardium is already fully infarcted.
But those rigid textbook rules completely break down here. The clinical reality is that if the patient is still experiencing severe pain and appears acutely unwell, the ischemic cascade is still active.
Meaning there is still dying, salvageable myocardium.
Yes. The text insists that thrombolysis should absolutely still be considered, regardless of that 18-hour mark, right alongside your standard aspirin, heparin, and analgesia. You treat the ongoing ischemia, not just the clock on the wall.
That makes total sense. And if you happen to note an incidental finding of an old inferior infarction, indicated by pathological Q waves and inverted T waves and leads 2, 3 in AVF, your clinical responsibility extends beyond just the acute event.
Right, because that patient requires really aggressive secondary prevention. Strict lipid control with statins, antiplatelet therapy, and likely a functional stress test to evaluate the need for angiography.
Which brings us perfectly to the great mimic. You are evaluating a 35-year-old man who complains of exertional chest pain and occasional exertional syncope.
Okay.
You pull the ECG and see massive, gross, symmetrical T-wave inversions across the anterolateral leads, so I, AVL, and V4 through V6. Now, those massive inversions usually scream one thing: a massive acute non-ST elevation myocardial infarction. You assume a critical LAD lesion.
Right, but you have to look at the patient profile. This is a young man with exertional syncope.
Right.
While extreme Q-wave inversion can represent severe ischemia in a young patient who lacks other voltage criteria for profound hypertensive left ventricular hypertrophy, this specific gross anterolateral repolarization abnormality is a classic hallmark of hypertrophic cardiomyopathy, or HCM.
Wow. So it is not an atherosclerotic plumbing problem at all.
Not at all. It is a genetic mutation causing a massive disorganized hypertrophy of the myocardium, specifically the interventricular septum.
And the physical exam signs for this are just a masterclass in hemodynamics. Because that thickened septum bulges into the left ventricular outflow tract, it creates a dynamic obstruction.
Yes.
So when you palpate the carotid pulse, you feel what's called a jerky pulse, a rapid initial upstroke as the ventricle starts to empty, followed immediately by a sharp decline as that hypertrophied septum literally gets sucked across the outflow tract, obstructing the rest of the stroke volume.
It's wild. But honestly, the most brilliant physiological pearl in the text involves the auscultation of the harsh systolic ejection murmur.
Oh, this is fascinating.
If you listen really closely, this murmur gets characteristically louder following a premature ventricular contraction, or PVC.
Wait, why would a PVC make it louder?
Well, if you map the mechanics,
Yeah.
the PVC causes a compensatory pause. The heart rests for an extra second, which massively increases the diastolic filling time.
Okay, and increased filling time means increased preload.
Exactly. And according to the Frank-Starling mechanism, the extra stretch on those myocardial fibers causes the left ventricle to contract significantly harder on the very next beat.
Oh, so that hypercontractile squeeze forcefully narrows the outflow tract even further against that bulky septum.
Yes, worsening the obstruction and driving up the volume of the murmur.
It's an incredibly elegant physical sign for just a terrifying pathology. I mean, an echocardiogram will confirm the asymmetric septal hypertrophy and demonstrate systolic anterior movement, or SAM, of the mitral valve apparatus, where the valve leaflets are literally pulled into the outflow tract by the Venturi effect.
It really is a structural nightmare, presenting as an electrical mystery.
Which honestly brings us full circle. The primary lesson from Professor Hampton is that your interpretation of the electrical tracing can never, ever be decoupled from the physiology of the patient in the bed.
Never. The ECG provides the vectors and the intervals, but the patient provides the hemodynamics, the history, and the context.
You cannot treat the paper. You have to treat the patient.
Exactly. And to ensure we're really cementing that philosophy, I want to leave you with a clinical exercise to review. Before you clock into your next shift, consider this scenario. You have a patient presenting with a broad, complex tachycardia, very similar to the post-MI ventricular tachycardia we just discussed. But unlike that crashing patient who required immediate cardioversion, this patient is sitting comfortably. They're fully conscious, with a blood pressure of 130/80.
So they are hemodynamically stable, but they are in VT.
Exactly. Knowing what we discussed about the escalating ladder of interventions for stable, narrow, complex tachycardias, how does your management pathway adapt for a stable, broad, complex tachycardia? Think critically about the pharmacology.
What specific antiarrhythmic agents would you prepare?
Right, and what physiological parameters are you constantly monitoring before you ever even consider reaching for the defibrillator?
It's a great question. Rely on your synthesis of the mechanics, trust your clinical exam, and whatever you do, don't let the squiggles on the page panic you. Take that question with you onto the wards, and we'll catch you on the next deep dive.